Thank you, Dr. Gleave. Hi, everyone. I'm Amanda. I'm R2 in urology. Thank you so much for being here. So today for my Grand Rounds topic, I'm going to be talking about surgical regret. Before I get started, I just wanted to say just the biggest, hugest, most massive thank you to Dr. Kavanaugh for not only guiding me towards an appropriate topic for Grand Rounds, but also for just spending so much time going through every slide and helping me prepare for them. So if Dr. Kavanaugh, you are here, I appreciate you.
I'm here, thanks.
So starting with a case study, so Hamlin versus Stanton was a case study that that actually happened not too long ago. Sorry, can I be able to just hide? I'm just gonna. Sorry, Jason, am I able to hide everyone else besides myself? Because I just have some notes here. Yeah, yeah. Sorry. Can you still see the slides? Okay, I think we'll just go with this. Okay, sorry everyone. So this is a case, Hamlin versus Stanton. It was a medical malpractice case that happened not too long ago, actually. So in 2017, a patient, Hamlin, who's the plaintiff, he received a diagnosis of prostate cancer, and he was told by his urologist, who was the defendant, Dr. Stanton, that he needed some form of active treatment. So the patient elected to go forth with surgery, and he received a radical prostatectomy. However, he did experience a lot of post-op complications in the immediate post-op period. He had a retroperitoneal collection, he had an ileus, he had a C. diff infection. He also experiences some long-term consequences as well. So he has ongoing urinary and fecal incontinence. And of course, a lot of stress and anxiety associated with all of this that's going on.
Amanda, is this in the US or in Canada?
It's in the US. Yeah. So the patient's case was that the injuries and disabilities that he has since suffered because of the surgery could really have been all avoided if he had just received a fully informed explanation about the different treatment options. He says that radiation therapy was mentioned by the urologist, but it was done so sort of in passing, and the urologist sort of steered him towards surgery. And he thinks that Dr. Stanton should have referred him or offered a referral to radiation oncologists. And he thinks that if he had been more well informed, he would have actually chosen to pursue with radiation and would have been able to avoid all these complications associated with surgery. So what happened is that in 2019, the patient filed a lawsuit against the urologist for damages for personal injury. And he would have been awarded $470,000. But the court ruled against him. So this case is a really good example where experiencing regret after surgery led to really palpable consequences and legal implications as well. And also illustrates a lot of things that we'll review today. So in terms of things that we will review today, I was hoping to define surgical regret in the context of urology, and then review the impact of regret on patients and on urologists, and then talk about methods that we can modify or prevent regret. So starting with the definition of regret. So the definition of regret in the context of healthcare really has two different components to it. The first is sort of a past-looking, effective concept of regret that none of us are strangers to. It's that highly negative emotion caused by the feeling that the outcome would have been better if we had actually done something different, made a different choice, etc. And the second component is more of a cognitive forward-thinking concept where you take into consideration the regret that you might experience as a consequence of the decision you're making in healthcare when you're making these decisions. And that's defined as anticipated regret. And the basis of this is expectancy value theory, which suggests that motivators for health behavior include expectations about the chances and extent of future outcomes. So the study of anticipated regret really started in the 1990s. And since then, it's been really well established that anticipated regret impacts decision-making in medicine. And more recently, there's a lot more studies emerging using regret as a novel risk appraisal tool. So understanding the role of regret is really important in optimizing and framing the discussion we have around surgery. So this is a systematic review that was published in 2017, and it identified 73 studies that looked to quantify regret after surgery and aimed to characterize factors associated with or predictive of regret. So they included studies in patients who are undergoing surgery for a disease process. So things like cosmetic surgery were excluded besides recon after surgery. And their definition of regret is essentially any study that used a validated method to assess regret, and studies that didn't meet that criteria were excluded. So there are several validated methods of assessing regret in the literature, but most of the studies tend to gravitate towards using the decision regret scale, the DRS, and it's shown here on the right side. It was a scale that's validated in 2003 in the clinical setting. It's a 5-point Likert scale questionnaire with 5 questions, and includes, like, was this the right decision to make? I regret the choice that was made. I would go for the same choice in the future. The choice did me a lot of harm. The decision was a wise choice. So this is what they use to operationalize regret most of the time. So what they found in the systematic review was that most of the studies examining patient regret after surgery was in surgeries associated with cancer, and non-oncologic surgeries, which included thoracic sympathectomy and pelvic organ prolapse surgery. Those were less than the oncologic surgeries. And they actually found there was actually urology that had the highest number of studies with respect to regret. The prevalence of regret overall after surgery was 14%, but the prevalence of regret was highest in prostate cancer studies, and then it was breast cancer studies, and then surgeries for non-oncologic pathologies. So they found several things that seem to be predictive of regret after surgery, and I've just grouped them into themes. In terms of patient factors, minority race, younger age, lower education level, and lower socioeconomic status were associated with regret. In terms of factors more related to the surgery itself, the invasiveness of the surgery, having long-term postoperative symptoms affecting quality of life, and the amount of time that's since passed since the original surgery dates were also associated with regret. And lastly, I put this under physician factors, but it's more like perioperative factors. But in the preoperative period, having the patient and physician decide on the surgery at the same time rather than someone solo, as well as the level of patient participation in decision-making was associated with less regret. So defining regret in urology, there really isn't any data out there regarding cystectomies, nephrectomies, but there is a lot of data related to prostate cancer. So this is a study that was a population-based prospective cohort study that was published in 2021 in JAMA Oncology, and it looked at around 2,000 patients examining regret in localized prostate cancer. So men that were diagnosed at the age of 80 or younger with localized prostate cancer between 2011 and 2012 were included. They had received either surgery, radiation therapy, or went through active surveillance. And those who got ablation or hormonal therapy, they were excluded from the study. And then these patients were given questionnaires at certain time points. The way that they defined and assessed regret here was based on this previously validated prostate cancer-oriented scale. So what they found was that overall, 13% of patients reported treatment-related regret at 5 years. Most of those patients had actually gone through surgical treatment, 13%. Next was radiation therapy at 11%, and the lowest was active surveillance at 7%. They also stratified the patients according to their level of risk. And after doing that, they found that in patients with low and intermediate risk disease, active treatments of surgery or radiotherapy was associated with a higher likelihood of regret, though this effect was reversed in higher risk patients. And then when they were looking only at characteristics available at baseline, the PDM score, which is the participatory decision-making tool, is just another questionnaire that they provided patients to look at how much how involved they were when they were making the decision to proceed with certain therapy. So that scores of that, social support, and age were all independently inversely correlated with the likelihood of regret. And then they also examined exposures associated with regret, and they controlled for functional outcomes, treatment modality, baseline demographic, clinical characteristics. And what they found was that the effect estimate for the association of the patient's perception of both treatment effectiveness and treatment adverse effects compared with expectations were larger than for any other variable examined. Changes in sexual function was also really important and significantly associated with regret. And lastly, scoring higher on the PDM-7 was inversely associated with regret. So those who participated more in their care were less likely to experience regret after surgery. They also did a sensitivity analysis and looked at scores at 3 years versus 5 years and didn't really find a difference in the proportion of patients expressing regret overall and the proportion of patients expressing regret after a certain modality of treatment. So not really any differences there. So what this study really seemed to show is that having a disconnect between patient expectations and treatment outcomes in relation to treatment efficacy and toxicity contributes substantially to treatment-related regret. For example, if a patient expects the treatment toxicity to be low and then afterwards it ends up high, and this is when regret is experienced. So there's another study of around 900 patients. It was published in the Journal of Clinical Oncology in 2017. And men who were under 75 at the time of diagnosis, who were newly diagnosed with prostate cancer between 94 and 95 from 6 different institutions were included. These patients either underwent conservative treatment, surgery, or radiation, and then surgery. And then similar to previous study, they were surveyed at certain time points. So really similar to what they found in the previous study, 15 years after treatment, 14% of patients experienced regret. Most patients experience regret after having the radiation plus surgery of 16%, compared to surgery itself, which is 15%, and then conservative treatment at 8%. They also reported that moderate or large sexual function bother were significantly associated with regret, and factors that were independently inversely associated with regret were older age and have made an informed decision. So the results of this study are very, very similar to the previous study, having that dissonance between what the post-operative experience is and what was expected from the patient, or in other words, just being unprepared for prostate treatment efficacy and treatment complications seems to be highly associated with regret. So I found this study. It was a German study that was published last year, and it aimed to compare regret following robot-assisted prostatectomy and open prostatectomy at 15 months after surgery. It included a total of 642 patients who were surveyed between April and June in 2021 in 20 different German centers. 277 patients went for open radical prostatectomy, and 360 patients went for a RALP. Patients who got a laparoscopic prostatectomy were excluded. Those who had metastatic disease were also excluded. And the way that they looked at regret was using the DRS here. And what they found was that 46.2% of patients who had went through open prostatectomy had higher DRS scores compared to RAL patients who had 28.1%. Again, lower patient age was seen to be associated with regret here. Stress, incontinence, and also positive lymph node status were also associated with regret. However, consensual decision-making was inversely associated with regret.
Quick question on that. Just interpret DRS scores. Higher DRS scores means more regret. Is that right?
Yeah, exactly. Like on a scale of 1 to 5, how much did you regret this? How much did it cause you harm? So a higher score indicates higher regret. So moving on to transplant. Transplant really just focuses on donor regret. There's not data existing regarding recipient regret, which kind of makes sense. This was a review that was published in The Lancet in 2013. It was reviewing all articles published between 1989 and 2015. And there were only 4 studies looking at patient regret after kidney donation. In these studies, regret wasn't actually assessed using a validated method, but rather they just sort of tacked on the question of, did you regret the surgery? And so they found the regret was ranged between 1 to 10%. There were 2 studies that found that regret was associated with graft failure in the recipients, and also studies showed that regret was associated with negative perceptions of their own health and poor social functioning as well. Moving on to pediatric studies, I found this interesting because there's 2 different perspectives we can take for peds. So we can look at parental decision regret, but we can also look at regret in adults who received procedures as a child. So in this first study, this was a systematic review from a group in Australia in 2021, and they were aiming to establish the prevalence and predictive factors for parental decision regret in distal hypospadia surgery. So there were 4 studies included with around 700 patients, and they used the DRS to quantify regret here. And what they found was the mean prevalence of decision regret was around 65%, and 20% of those had moderate to severe decision regret. And predictors of regret were post-op complications, preferences around circumcision, if there was conflict between the parents, if the parents had low education level, if the patient was not a firstborn, and if there was an initial desire to avoid surgery. These were all associated with higher levels of regret. There was also this interesting survey in 2022 from a group in Indianapolis, and they looked at decisional regret in patients with spina bifida regarding the decisions that their caregivers made to manage their neurogenic bladder when they were children. So between 2018 and 2020, they surveyed adult spina bifida patients at clinic appointments using the DRS. And overall, 40% of patients reported regret. Of those patients, 90% reported mild to moderate regret, and 4% reported strong or very strong regret. So predictors of regret that they found in the study was having bladder neck procedure and having quite bothersome urinary incontinence. Okay, and then so gender affirmation surgery. So this was a systematic review published in the Journal of Plastic and Reconstructive Surgery in 2021. And it looked at regret after gender affirmation surgery from patients in 14 different countries. There was a total of 27 studies, around 8,000 patients were included up until 2020. And they included articles that had patients age 13 or older who underwent gender affirmation surgery and reported either regret or they went through detransition. And just to note, most studies here are conducted to non-validated questionnaires like semi-structured interviews to operationalize regret. So what they found was, of all of the studies, 33% of procedures were transmasculine procedures and 67% were transfeminine procedures. From all transmasculine surgeries, most of it was mastectomies and then phalloplasties and then hysterectomies. For transfeminine surgeries, most of them were vaginoplasties and then clitoroplasty, breast augmentation, and then vulvoplasty. And what they found was that the pooled prevalence of regret was actually really quite low. It was 1%. The prevalence of regret for surgery in transgender men was less than 1%, and for transgender women, it was 1%. Most of the regret seemed to be centered around vaginoplasty at 2%. And some of the main themes that were identified here to be associated with regret was really around psychosocial circumstances, particularly difficulties returning to society within their new gender roles, difficult family environment, poor social support. Also, studies found that if you were heterosexual preference, it was highly associated with regret. And if you had an evident personality disorder, that was also associated with regret too. And then more so surgical factors was a loss of clitoral sensation, chronic abdo pain, and then there were some studies that said that just the aesthetics, if they weren't up to the patient's standards, that was also associated with regret. And interestingly enough, 71 of patients with regret actually underwent detransition surgeries, and similar risk factors, predictive factors, social regret, feeling non-binary, and most of them were mastectomies. So studies of urinary incontinence. So this was a retrospective study that was done in San Francisco between 2015 and 2020. It was a cohort of 130 males over the age of 65 years old that were seen in consultation for stress urinary incontinence. And what they wanted to do was to quantify regret and identify predictive factors associated with it. And they use the DRE or the DRS to operationalize regret, not the DRE. DRE just rolls off the tongue, sorry. And what they found was that 22% of men have moderate or high regret with their treatment choice. DRS scores are highest in conservative management at 34%. And then there wasn't really much difference between sling and sphincter at 8%. And the predictors of higher amounts of regret was a higher incontinence score. And something that sounded protective was utilization of shared decision making. So this is another study, just briefly a retrospective review of 41 patients in Oklahoma between 2009 and 2020, looking at patient factors associated with high DRS scores when it comes to urinary incontinence procedures. Again, similar to previously, the prevalence was 21%. And predictors of regret included history of radiation and the choice of procedure, and also the need of surgical revision as well. So I think it's pretty clear that regret reaches most, if not all, of urology. So I think it's really important that we think about the impact of regret on both patients and physicians alike. So when it comes to patients, regret can have quite a negative psychosocial impact on patients. In general, regret's been linked to feelings of blame, poor self-image, poor quality of life, And studies of decision regret in breast cancer have been linked to more rumination and depression as well. Regret also acts as a driver for future decision making, whether that be a patient just completely avoiding surgery for the rest of their life or seeking out more surgery to fix the issues that they regret. And moreover, the physician-patient relationship can be undermined when there is instances of regret. So there have been reports of lower satisfaction, negative future experiences, and low levels of trust. Lastly, there are studies in business and marketing that have shown that customers who receive bad service encounters that they regret tend to launch more complaints. There aren't any studies really linking regret with medical legal implications. However, we see it a lot in the news, and we see it in the case reports, that earlier case report that I presented as well. So it is there, and there's an association, so we should examine it. So this is a review of around 6,000 closed urologic claims from the data set gathered by Physician Insurers Association of America between 1985 to 2012. And they identified urology as quite a moderate to high-risk specialty with an 11% chance of being implicated in a malpractice claim each year. So most commonly, it's due to improper performance of the procedure. That's like 38%. Errors in diagnosis is common as well, failure to recognize complications. But interestingly, in around 20% of cases, there was no identifiable medical misadventures. So we can really extrapolate that patients who file a lawsuit likely regrets their surgery, not the other way around. Litigation is going to be used as a surrogate marker for regret here to look at the impact of physicians. So the impact of on physicians when it comes to litigation is really significant. So, for example, in a survey of around 300 patients with both open and closed claims from the previous year, they found that over half of these physicians noted really quite damaging psychological impacts, including low mood, insomnia, nightmares. They also reported aggravation of existing pathology, onset of new pathologies that were mostly like MSK, cardiothoracic in nature, increased use in substances, and also diminished career satisfaction as well. They also found that there was an impact on practice changes. So most notably, the use of defensive medical practices increased quite a bit. So things like hypervigilance, viewing patients as potential plaintiffs, paying greater attention to documentation, actually going for medical legal training, ordering investigations that are not necessarily indicated, and avoiding certain patients or avoiding certain procedures were found to be highly associated after litigation. There's also this concept that physicians who have been sued kind of, subliminally act in a different way. So there was this survey that was done around 12,000 patients with 65 surgeons and 59 family doctors. They analyzed patient encounters. Half of these physicians had no history of malpractice claims, and the other half had 2 or more lifetime claims. Interestingly, what they found was that for the most part, they were really accurately able to classify whether a physician, had no history of malpractice claims or whether they did, just based on how they communicated. So they had shorter visits by 3 minutes. They had less partnership type exchanges, less humor, less laughter in the interaction, and less review of patient expectations as well. So patients who underwent this interaction felt like the physicians who had been sued in the past just really didn't like and didn't respect them. So it's sort of a vicious cycle. You get sued and the way you act is a bit different. Patients are a little less happy, more regret, more likely to file a lawsuit, and then it just keeps on going. So because of that, I think it's really important to try to take a look at ways that we can prevent regret. So I think a very common theme here is that regret is really everywhere, but it is a modifiable factor that's important in framing the discussion around surgery. So here is a list of the predictors of regret that we have identified so far, and we can simplify and group them into common themes. So I group them into sort of patient, surgical, pre-op, physician factors, and you can simplify even more to some broad themes. So as previously mentioned, older age, a lower socioeconomic status, minority race, lower education level are associated with regret. Obviously, we can't really modify patient factors, but primarily I think it's important that we are able to identify patients who are at higher risk of regret or have been identified to be more associated with regret postoperatively. And then as previously managed, the sort of dissonance between patients' expected outcomes versus what the true outcomes are seem to be a crucial factor. Postoperative symptoms affecting quality of life are also substantial. And lastly, active participation in the decision for surgery is inversely associated with regret. So if we can, in the preoperative period, manage patients' expectations with regards to their postoperative symptoms while actively engaging them in the decision-making process, we can likely prevent regret. And there are studies on this. So this was a systematic review that was published earlier this year. So all studies looking at pre-op education on post-op recovery and abdominal surgeries between 2011 and 2022 were examined. They narrowed it down to 12 relevant studies to include in the analysis. And what they found was that with intervention, which was additional patient education, many studies reported reduced post-op complications, reduced length of hospital stay, reduced post-op pain, also reduced negative affect and anxiety as well. And the authors mentioned that just by providing the patients with additional knowledge, setting realistic expectations, providing that mental preparation surrounding the short-term post-op course, and presumably long-term quality of life implications seems to not only have positive psychological effects, but also generates palpable changes as well. And there are a lot of other studies that look at this as well across different specialties. I'm not going to lie, I did not go into these studies because they were not urology, but just from a quick Google search, you can see, spine, ortho, cardiac surgery, gen surg, also studies looking at interventions provided by nursing staff rather than physicians. They all just seem to have a plethora of positive impacts on patients postoperatively. So, in summary, regret is prevalent in urology. We've seen that regret has significant impacts on patients and physicians alike. However, regret is a modifiable factor. So if we can identify patients who are at higher risk of post-op regret, we can provide pre-op management of patient expectations regarding the post-op symptoms affecting their quality of life, and then allowing patients to have an active role in decision-making if it aligns with their preferences. And hopefully, if we can all keep this at the back of our mind, we can all live with no regrets, like Scotty P. Thank you.